talk about Tandem and Ovoids. So just like last week, we'll go through some learning objectives here. We would like for you to be able to recognize the operational process in developing treatment plan for brachytherapy, to be able to perform HDR treatment planning for a variety of applicator types, to perform plan checks on HDR brachytherapy treatment plans, and to understand uncertainties involved in HDR brachytherapy planning and delivery. So very similar to our objectives from last week. Similarly to last week, we're essentially going to walk through from commissioning all the way through the treatment process. So we're going to look at pre-planning, which is a little bit different in the case of Tandem and Ovoids. We'll look at insertion, just as we did last week, patient transport, imaging, applicator reconstruction, and planning aims and prescription. So last week, we were looking at treating the intact vagina when the uterus had been removed or when the patient had had a hysterectomy. This week, we're going to be looking at treating the cervix and the uterus. So this is with intact cervix and uterus. We're looking at treating those as opposed to the vaginal wall or vaginal cuff, like we were talking about last week. So here's what Tandem and Ovoid look like. You have this central catheter. These are from different manufacturers. You have this central catheter that runs down the middle and then has some degree of bend in the catheter. And you would choose the length of that catheter and the specific bend in that catheter to match the patient anatomy. So the Tandem is inserted through the cervix and into the uterus, typically goes right to the end of the uterus or right to the fundus of the uterus. And then on the side of that Tandem, we have two ovoids, one on each side. These are the ovoids here. And the ovoids are essentially a single channel, single catheter, and then they have this plastic material around them. And the purpose of that plastic material, just like the cylinder, is to sort of move the high dose region of the dose distribution away from tissue. And it gives us a little bit more dose fall off as well. So these are three different examples of what Tandem and Ovoids look like. One of the nice things about Tandem and Ovoids is that there's not really a fixed geometry associated with these, or for most of them in any case. So you can move the tandems laterally with respect to the you can move the ovoids laterally with respect to the central tandem. So it gives you some ability to modulate the dose distribution given how you set up or how you lock in your tandem and ovoid positions. The downside to that is it's not a fixed geometry, so you do need to plan every case for every patient. Okay, tandem and ovoid applicators used to treat cervical cancer. That's what we just talked about. And target dose to cervix and the uterus. And the purpose of doing this is it's typically used in combination with external beam radiation therapy. So the patient would go through a course of external beam radiation therapy. Once they're finished that course, then we would have used tandem and ovoid to boost the cervix and uterus regions. And it's actually been shown that in order to have a curative treatment for cervical cancer, you need to add this boost. And people have thought about adding boost with newer techniques like SBRT, where we would sort of do a very targeted external beam dose. And they've shown that it's just not possible to get enough dose to the uterus and the cervix using external beam because we go over our dose tolerances for our organs at risk. So the only way for us to be able to get enough dose to the cervix and uterus to have a curative dose or to cure our patients definitively is to use brachytherapy. So it's kind of a combination of external beam and then boosting with brachytherapy. Any questions or comments around that? Kind of all on the same page so far? Okay.
Yes, thank you.
Thanks, Sherry. We talked also about this dose distribution that we call the pear-shaped dose distribution. And this really comes from our tandem and ovoids. And you can kind of see that here. So this is a CT scan with a tandem inside the uterus. And here are two ovoids on either side of the tandem. And we're going to load our tandem and ovoids such that we have this sort of pear-shaped distribution. We also talked about last week this point A, which is going to be our prescription point, and we'll talk more about that in just a minute. But often in brachytherapy and HDR brachytherapy, tandem and ovoid are going to be sort of the most common applicator that we're going to use, and we're going to talk about this pear-shaped dose distribution. We really want to see this for most of our cases. The pear can be larger, the pear can be smaller, the pear can be longer and shorter, but we're always going to have this sort of pear-shaped dose distribution. And you can see that here. And it's kind of a good check for you as well when you're looking at your dose distributions. If you had your 100% isodose line, which is the yellow line here, if it was coming way down here, if you can follow my cursor there, if it was coming way down here, it's starting to look less like a pear. And you could think to yourself, maybe something's not quite right about this. Maybe we've loaded the tandem too far down, or maybe something else is strange. We better have a second look at it. So anytime I'm looking at a dose distribution, I have that in my mind. Oh, Scott, it should look something like this. And if it doesn't look something like this, we need a really good explanation for why that's the case. As with all treatment applicators, each component needs to be commissioned. So we're going to do a visual inspection, we'll do functional tests, we'll do imaging tests, autoradiographs. This is all very similar to what we talked about as well with the cylinder case. Here you see two-dimensional planar X-ray image of a tandem with a dummy wires in here. So you can see all of the different seed positions and where they happen within both the ovoids and the tandem. We should also, of course, do on an annual basis to make sure that everything is working and in order. So just as a bit of a side story, we recently had a case where we had a tandem, and at the end of the tandem was a little connecting piece, and it was supposed to be always connected, like it was glued on there, should never have come off. But over the course of time and over the course of sterilization, that piece had started to slip a little bit. And so we noticed sort of slowly that the tandem length was getting longer, and the tandem is a piece of metal, so it shouldn't change length at all. But over the course of several months, the tandem went from what we expected the length to be to about plus 3 millimeters. And at that point, we were thinking, what is going on? How is this possible that the tandem can be changing length? It can't be. So we looked at the device and couldn't really figure out what was going on. And eventually we put enough force on it and noticed that one little cap at the end actually could slide forward. So it had started to pull off. So just important to be able to do these visual inspections and just notice what's going on over the course of time as you're using these devices. The sterilization processes can be pretty tough on these devices, so good to always make sure you're have an eye out for that. And also, yeah, go
Dr.
ahead.
Brown, out of curiosity, did you catch that by imaging the device on an annual basis?
We did not. We caught it by recognizing that the length was changing.
I see.
Yeah,
Thank you.
I actually don't think we would have caught it just through visual inspection because it looked like it was in the right spot. It wasn't until you pushed it back that you realized it was starting to come off.
Interesting. Thanks.
Okay, so here's this idea of point A, and this is we talked a little bit about this last week, and I know there was some interest last week, so I want to take some time and go over this in some detail. So recognizing that it's not absolutely a fixed geometry, but what happens is before we had the ability to use three-dimensional imaging, so CT scans or MRIs, we had to plan all of our patients using two-dimensional images. And some of us on the call will still be doing that, and that's totally fine. When we were using that strategy, we didn't have the ability to see where the cervix was. So we had to say, all right, for most of our patients, if we use this point A, we're going to cover the cervix. And point A is defined as 2 centimeters up from the ovoid, so cervical os, 2 centimeters along the tandem, always in the plane of the tandem, and then 2 centimeters laterally, left and right. So we're going to have point A over here as well. So 2 centimeters up, 2 centimeters lateral. If the tandem was coming in like this, so the tandem may be a little bit off center, we would go still up the tandem and then 2 centimeters this way and 2 centimeters that way. So point A is always with respect to the tandem. And we decided a long time ago, if we prescribe 100% of our isodose line to that point A for 95% of our patients, that's going to cover the cervix, right? We can't see it, so we're kind of treating blind, and this is going to, this is the best that we can do. What we do nowadays, if possible, if we have three-dimensional imaging available, either CT or MRI or both, then we can actually see where the tumor is, and we can start to modify the dose distribution to better cover the tumor, or in most cases, to better spare the organs at risk. So bladder, sigmoid, and rectum. So this we're still going to use when we have three-dimensional imaging systems available, CT or MRI. We're still going to use this point A as kind of our base plan. So whenever we generate a plan using 3D CT images, we're always going to create a plan. The first plan we create is always to this point A. And then we're going to look at that plan and we're going to modulate the dose distribution based on the specific patient anatomy. But point A is always going to be sort of our starting point. So you can think of that as kind of a pre-plan in some context. Does anybody have any questions about point A? I know we had a lot of interest last week about it. Are there any questions in the chat, Sherry? No.
No, nothing at the moment. I'll let you know when we do. Thanks.
Okay. So because we're going to prescribe to point A, we can have this sort of starting applicator loading position. So we're going to predetermine our dwell positions and weights in the tandem, and we're going to predetermine our dwell positions and weights or length of time, this means, in the ovoid. So this can be used for patients in treatment planning system as a starting point. This is what we just said. And these patterns are, of course, dependent on the length of the tandem and the size of the ovoids. So I didn't mention that earlier, but the ovoids also come in different diameters. And the loading patterns that we're going to use, standard loading patterns that we're going to use, are dependent on those two things, which means we're going to need a standard loading pattern for every combination of tandem and ovoid that we're going to use clinically. So we can create these plans just on a CT scan. We don't need a patient at this point. Applicator does not need to be inside the patient. We're going to normalize 100% of our prescription to point A, both on the left and the right of the patient. But because we don't have any three-dimensional anatomy, we're not going to be able to optimize for OARs, bladder, rectum, and sigmoid at this stage. Okay, so here's what our loading patterns are typically going to look like. You have two options here. You can use evenly spaced dwell positions with different dwell weights. So that's what you're seeing up here in the top right. These little green boxes are showing us possible dwell positions, and they're all one right next to each other, right? So these are sort of equally spaced dwell positions. And then what we would do in this case is for the top third of the tandem. So we have the top third, middle third, and bottom third. For the top third, we're going to increase the dwell time weight. So we'll have 1.5 times the weight in the top third that we will in the bottom. Does anybody know why that would be the case? Thinking back to last week when we talked about the hourglass with the cylinder, why would we need more dwell time in the top third?
And please feel free to unmute yourself when they're like this. Like, answers are encouraged.
I think so.
Yeah, that's exactly right. In the same way that when we were looking at the cylinder, we needed to have more dwell time at the end of the cylinder because we had less contribution from all of these dose points. So if we're looking at a dose point here, this is getting dose contribution from all of these dwell times. If we're looking at a dose point up here, it's getting contribution from many fewer dwell positions. So we need to increase the time here. So we'll have 1.5 times here. So let's just say as an example, we have 15 seconds in each one of these. Then we would have 10 seconds in each one of the remaining ones. And then we would go back to 15 seconds for our ovoids, and that would give us this sort of standard loading pattern. And then we would just normalize that 15 seconds and that 10 seconds, keeping the same ratios until our 100% isodose line hit our point A. Once we got there, we would stop. And that would be our standard plan for our tandem and ovoid, and that would be always a starting point for our tandem and ovoid treatments. Another option here is to vary the spacing of the dwell positions, and that's what you see at the bottom here. So you see the top third, you have dwell positions at every possible position, and then in the bottom 2/3, you have one at every second position, right? And then we can use the same dwell times in each one of those positions, and it's going to have the same effect as what happened up here. So those are two different options. And then again, we're going to normalize our times until our 100% isodose lines reach our point A. Sound good? So two different options there, both equally valid. Okay, ovoid loading. So we talked mostly about tandem loading there, ovoid loading. We're going to use evenly spaced dwell positions along the length of the ovoid, but we're not going to run past the bend in the ovoid. So here's the ovoid coming in, you can't see the plastic part here. You're just seeing the central catheter in the ovoid, and this is the bend in the ovoid. And typically we want to center our dwell positions around where the tandem crosses that ovoid. And we would never load beyond the bend in this ovoid. Same number of dwell positions in both the right and the left ovoids. And then again, we're going to normalize our dose until we get our 100% isodose line through point A, both on the left. Okay, so this is the starting point, right? We're not finished yet, right? But it's always going to be our starting point. It's what we do in our clinic, and I think it's what RCC would recommend everybody does as a starting point. Okay, so here's our standard plan. So this is the same patient, same image, actually, just two different dose distributions. So here's our standard plan for this patient. So we did the insertion, did the 3D imaging, and we did the digitization, and now we're doing the planning. We're going to talk about all of those things coming up. But here, looking at this plan, here's our standard plan. So our 100% isodose is going through our point A. We've normalized everything. And then we're going to look at that plan. We're going to say, hey, for this patient, I think we're going to treat way too much bladder if we use the standard plan. So let's reduce that dose until we're happy with the bladder dose, and we still feel like we're covering the tumor volume adequately. So then we can start optimizing the plan. And this one has been pretty severely optimized, I think, just for the purpose of showing that you don't need to actually treat with the standard plan. You can optimize it to make sure that your dose to organs at risk and dose to the target volume are where you want them to be before you treat. But we're always going to start here and then get to here. In some of our patients, we don't change this at all because it's perfect. It's good enough. In some of our patients, we change it a lot. Why? Because patients have significantly different anatomies. Okay. So here's our first poll question. When creating a standard plan or loading pattern for the Tandem and Ovoid style applicator, how do you get a uniform dose along the tandem? Option A, equally spaced dwell positions with equal dwell weights. Option B, equally spaced dwell positions with lower dwell weights at the tip. Option C, equal dwell weights with dwell positions more closely spaced at the base or the inferior end of the tandem, or equal dwell weights with dwell positions more closely spaced at the tip of the tandem. That's a tough one.
All right, and I'm gonna go ahead and punch. Since I'm not the original host, but that should not be a problem. Are you also host, Dr. Brown?
I am
Did you claim
not,
the
but
host?
I can try.
No, I am the host. I can unmute everyone and I see the functionality, but for some reason it does not let me launch the poll. Interesting.
Do you see the poll? Do you see
Yep,
how you launch it?
Yep. And I am launching it, but it says not the original meeting host. That must be the new upgrade in Zoom because I've done this. All right, sorry about that, everyone. Yeah, that's gonna take a screenshot just so talk to. All right, yeah. If anybody, if we all would like to put our answers in the chat, and we're gonna give about 30 seconds to everyone. Sorry about that. Not sure. Yeah, because I'm not the original host. So we have some A, D. It's between A and D. Raham, do you have a question? You have your hand raised. Or would you like to answer the poll question in the chat? All right, we're going more with D. Oh, now we have some Bs. D. All right, great. Thank you, everyone, for participating.
Yeah, that works just as well.
Yeah, sorry about that.
Yeah, no problem, no problem. Okay, so the answer is D. And let's talk about why that would be the case. So if you remember when we were looking at that a couple slides ago, we needed to have either more dwell positions or more dwell time at the tip of the tandem and fewer positions or lower dwell time at the base of the tandem. So that's why we have the answer is D, equal dwell weights with dwell positions more closely spaced at the tip of the tandem. So remember, if we go back up here, slides, this was coming from this slide where we had these two options, right? So either we could have more time at the tip, or we could have more dwell positions at the tip of the catheter. So let's look at A, because A was sort of a common one, right? Equally spaced dwell positions with equal dwell weights. So if we had those equally spaced dwell positions, we wouldn't have enough dose at the top of the tandem because we don't have enough dwell positions contributing dose at that location. Someone has a raised hand, but I'm not sure if they also have a question.
Yeah. Reynolds, do you have any questions? Would you like to ask your question? Do you want to write it in the chat? You have your hand raised.
Okay, we'll see
Okay.
what happens. Maybe it's
All
just
right,
giving us a high five.
Sorry, it was a mistake. Yep. High five right back at you.
Okay, so we talked about point A. We've talked about this sort of base plan that we're going to create to point A. Now let's go back a few steps and let's talk about the insertion. So tandem is inserted through the cervical os, as we talked about. So tandem is going to come through the vagina, through the cervical os, and into the uterus. So it's going to occupy this space here. And then the ovoids are going to be placed just to the left and to the right of that on the outside of the uterus, just right up against the cervix, as close to the cervix as possible. Okay, and then we're going to treat that pear-shaped dose distribution. We're going to get the uterus and the cervix with that pear-shaped dose distribution. So the insertion can sometimes go wrong, and it's actually not incredibly infrequent that it goes wrong. Patients have very, very variable anatomy. It can be sometimes difficult for the person placing it, typically the radiation oncologist, to be able to tell what's going on because it's difficult to see things during the insertion. And so here are some examples of where the insertion has gone wrong. So this patient actually, a uterus that has some fairly unique anatomy here. It's retroverted. So they've come in with the tandem here, expecting the uterus to be up here, and it's actually missed the uterus entirely. So it's not even gone through the cervical os. And here's the applicator here. So they've not been able to get in through the cervical os and into the uterus. And here's the same patient, I think. Here they've recognized the problem. They've come back out. They've managed to get the tandem through the cervix, and they've actually, with the tandem, managed to rotate the uterus back into what would be a usual position. It's not the correct position, but what would be a usual position. And then they managed to insert it here. Here's another example here. You can see the tandem has gone through the cervix into the uterus, and then it's gone back through the back wall of the uterus, and it's actually perforated the uterus. Here's another example. Here's the tandem. It's gone through the cervical os. It's gone into the uterus. Everything looks good, and then it's just been pushed too far. So it's just gone too far through the wall of the uterus. So those are things to keep in mind. These things do happen. It is not the end of the world. In this case, this could be pulled back and you could still treat, or you could select a smaller tandem length and insert a smaller tandem. Same in this case, a little bit more difficult because now you've created this channel here in the uterus and the uterine wall. So it's difficult to get past that. The tandem is going to want to sort of keep going through that same channel. So in this case, you may just take everything out and have the patient come back at a later date when this has had time to heal, and you could try and get into that uterus. If this happens in your clinic, don't think that it doesn't happen in other clinics. It happens in our clinic. It happens in many clinics in North America. It's a thing that happens. So don't think that it's terrible or unusual. Obviously, to try to avoid this, but it can be quite difficult to do these insertions.
Yeah. Dr. Brown, there's a question from Gregory in the chat asking if there are negative side effects using farm images to plan.
What kind of images?
It's spelled as FARM, farm. I'm not sure if I'm familiar with that. Gregory, would you like to maybe elaborate a little bit more?
C-arm images. C-arm images.
Oh, C-arm images.
CR.
So with CR images, we would typically be acquiring orthogonal images, right? Planar orthogonal images. And that is totally fine. And that's what, before we had the ability to do three-dimensional imaging, either with CT or MR, all of us were planning with two-dimensional images. So it's definitely possible. Until maybe 10 years ago, 15 years ago, it would have been considered standard of care for us in the US. And as long as you're using point A, then that could be considered standard of care. So the downside is you can't really see where the cervix is. So it's going to be hard to do any dose optimization, right? It's going to be hard to dose optimize for the bladder, and it's going to be hard to dose optimize for the rectum. But this is this is still considered standard of care, and it's definitely possible. And if that is the best imaging that you have available, then you're better off to use that than to not provide patients with tandem and ovoid treatments. Remember, we said at the start, tandem and ovoid brachytherapy, HDR brachytherapy, is necessary to be included along with external beam radiation in order to cure our patients. So we would much rather include that using whatever imaging technology that we have. We're going to create a standard plan to point A, and we'll treat the patient with our point A plan. Does
Thank you.
that make sense, Gregory?
Yes, yes, thank you.
Thank you. Thank you for the questions. And we do have some other great questions, if you don't mind, Dr. Brown.
Yeah.
Stefan is asking, does the patient have to go through an operation to mend the uterus in case it's pierced through?
Great question. So the uterus is a lot like the mouth. It heals itself incredibly quickly. So patient does not have to go through an operation. It's actually not that big a deal. Radiation oncologists don't like to do it because they feel like they've failed at their task, but it's really not a big deal at all. So no operation, nothing, no.
Thank you. Yvonne's asking, how do you determine the tandem and ovoid angle before insertion?
That is a great question. Typically, we would do that by looking at a CT scan that we had used to create an external beam plan. So remember, almost all of these patients are going to have an external beam plan. And for most of us, we're going to generate that external beam plan using CT-SIM. So we'll look at that CT-SIM, we'll measure the length of the uterus, and we'll try and figure out an angle as well for the tandem.
Thank you so much. Adaku is asking, with the C-arm, can we see when our applicators are not properly placed?
Again, it is a little bit more difficult. So using a C-arm, we would also recommend using a Foley catheter in the bladder, maybe even with some contrast in it, so you could know where the bladder was. And then we would also recommend putting some radio-opaque beads in the rectum, so you would be able to know where the rectum is, and that would give you some idea. And then of course you'll be able to see the bladder. You may, in some cases, depending on the size of the patient, depending on the quality of the image, you may in some cases be able to see the uterus and some of the anatomy. Just difficult to dose optimize. So I think the answer is yes, you would be able to see in most cases, given good image quality, you would be able to see that it was placed correctly.
Awesome. Thank you so much. And Abigail from Ghana is asking, would an image-guided applicator insertion help mitigate these insertion mistakes? Which imaging modalities would you suggest?
Yeah, that's such a great question. The answer is definitely yes. You know, it's a big endeavor to have sort of either CT guided or MR guided insertion, but yes, it would help tremendously. One thing that we use a lot, and you know, many of us would have this in our clinics already, is ultrasound imaging. So our radiation oncologists will often do transabdominal ultrasound imaging, live imaging, while they're doing the insertion. So if they're feeling not very confident about, you know, being able to get the tandem in the right place, then they'll ask for the ultrasound. They'll do a transabdominal ultrasound while they're doing the insertion, and then they can be sure that the tandem is getting into the uterus. But yeah, image guided anything is good.
Yeah, thank you. And Yvonne is asking, sometimes there's a lot of blood while inserting the tandem. Can this be due to perforation?
It can be due to perforation. It can also just be due to sort of irritating the uterine wall. So I don't think it's a definite indication of perforation, but you know, typically there's not a ton of blood. So if there's a lot of blood every time, then that may be indicating that there are perforations happening.
Wonderful. Thank you. We're caught up with our questions.
Excellent. Thanks, Sherry. Thanks, everybody. Those are great questions. So just like the cylinder, when we wanted to use the largest cylinder that was comfortable for the patient, we also want to use the largest ovoids. And the reason is the same. Helps avoid hot spots in the tissue, and it helps push the dose laterally if needed to cover the target volume. Same sort of reason as we had for the cylinder. If you have a rectal retractor, you're in luck. They're great. I'm a huge fan of these because they really help spare dose to the rectum. So what we're looking at here is, again, tandem coming in here, tandem going through the cervical os into the uterus, ovoids on each side. And then here we have this rectal retractor, and that you can see that here, and it's really just pushing the rectum away from our region of interest. So it's just like a physical, mechanical tool that does an amazing job of sparing dose to the rectum. I always appreciate when our radiation oncologists use this. It makes the planning so much easier because it essentially takes the rectum out of the equation. Another way to achieve this is to use packing. So you can use gauze, surgical gauze, and you can push surgical gauze in here underneath the tandem and ovoids, and it has the same effect pushing the rectum away. And some of our radiation oncologists do that very, very effectively, and that's great. And they use a lot of gauze. I'm always surprised. But the more gauze they use in there, the more they're pushing this rectum away, and the more it's sort of keeping the applicator in place, which is obviously what we would like as well. Patient transport is an interesting thing to think about in the context of using three-dimensional imaging systems. We're going to have some way of moving the patient from the table where we do the insertion onto the table where we're going to do the imaging. And in that context, obviously, we want to be thinking as much as possible about having the device immobilized in the patient, especially once we've completed the imaging. Again, we're going to have to move the patient from the imaging table back onto the surgical bed and back into the HDR suite for treatment. But we're going to do all of our imaging or all of our planning and dose optimization based on the images that we acquire. So if the device moves inside the patient between when we image the patient and when we treat the patient, then we're going to treat them with the wrong dose distribution, right? So very, very important, and purely a mechanical thing here. We want to do everything possible, keep the patient as comfortable as possible so that the device inside the patient does not change with respect to the anatomy of the patient. So,
Great.
Yep.
Dr. Brown, there's a question from Yvonne. They're asking about how you would comment about patient preparation, full bladder, empty rectum, and what is preferred, and if there's any literature on it, if you don't mind sharing.
Yep. So always empty rectum, again, just because the full rectum pushes the rectum into the area that we're trying to treat, and we don't want that. So as much as possible, empty rectum. So that one's kind of definitive. The idea of full versus empty bladder, I think, is less definitive. So some radiation oncologists always want to treat with a full bladder, with the idea that the bladder pushes some of the sigmoid and some of the bowel out of the way. And the bladder actually has a fairly high radiation tolerance. So they use that strategy for every single one of their patients. Some radiation oncologists think that that is not necessary at all. So I think it's kind of like, my guess would be that it is sort of dependent on patient anatomy. If you have a patient where you're having a very difficult time meeting the small bowel or sigmoid dose constraints, and you can see that if you filled up the bladder a little bit, it would push that away, then maybe I would think, all right, for the next fraction, let's fill the bladder and see if that bladder pushes the sigmoid out of the way. But for some patients, anatomically, that's just not going to make a difference at all. You know, some patients have really large bladders to start with. Some patients have really small bladders to start with. So bladder filling is a little bit more of a difficult question, and it's probably patient specific. Rectal filling is more definitive and should be avoided.
Wonderful, thank you. From Ghana, asking if you would advise both insertion and treatment to be on the same season.
Yeah, that would be great. It avoids having to move the patient, and that would be an amazing situation. I would love if in our clinic we could do that, but we can't because our CT scanner is too busy for that. And these procedures, you know, for us take 2 to 3 hours. So the CT people would be really angry at us if we tried to do that. But I would love to be able to do that. If we could buy our own CT scanner and just use it for HDR, that would be amazing.
Yeah, and Holiday is asking, what would you advise after the CT to return to the treatment room?
So anything you can think of, anything you can do to try and improve that immobilization. There are lots of different things you can do. One, packing was very easy, very cheap. We already mentioned this, and you can put a lot of packing in there. So it's very tight and it's held very tight inside the patient. You can also get these sort of, it's almost like a hovercraft transfer bed. So the patient just is always lying on this mat throughout the entire procedure, and you just plug it into a sort of something that blows air, and it sort of puffs up, blows air, and then you can shift them very easily from one bed to another bed without having to move them or without having to pull them on a sheet. There are lots of things like that. It's described here, a hover mat. One thing to avoid, and we've actually seen problems with this in our clinic, if we do try and lock, you remember when we were doing the cylinder treatment, we were locking it to a base plate. So it was very, very rigid and it wasn't going to move in the patient. If we do that with a Tandem and Ovoid, we've seen sometimes that patients will sort of squirm away from it and actually move significantly. It just serves as like a locking position for the patient to be able to move away from the device, and it's actually detrimental. So we typically won't use that at all. Just packing. You can also use gauze to wrap around the device and then wrap that gauze around the patient's shoulders, almost like suspenders. I know people have designed underwear that will also do the same sort of thing. Anything that you can think of. You need to get creative with your immobilization for Tandem and Ovoid. Imaging, some form of imaging is mandatory. Here we're seeing, this would be a CRM image for Gregory that was asking about CR images. So you can definitely see the Tandem and Ovoids. A little bit difficult to see what else is going on here. This is probably the Foley catheter in the bladder, but you can see it would be a little bit difficult to know if you had the tandem in the uterus from that image. We need to be able to see the applicator position for sure, because we need to digitize. Great if we can also see the tumor, the cervix and the uterus, and the bladder and the rectum. In order to be able to modify the standard loading, we're going to need three-dimensional images, because otherwise we're not going to be able to see our treatment volume, our high-risk CTV, or our organs at risk. Okay, applicator reconstruction. So we've inserted the device in the patient. We've taken them over to the CT scanner or MR scanner. We've acquired three-dimensional images. We get our patient back into the treatment room, and then we're going to get to work digitizing and contouring and treatment planning, right? So Tandem and Ovoid applicators can be reconstructed in multiple ways. We can use a solid applicator model and then deform that or move that around until it matches. I have never seen people use this with very much success, to be honest. I have not used all of the standard library models, but the ones that I have used, I've seen limited success. I would just rather go ahead and manually reconstruct those Tandem and Ovoids on a 3D image set or on a 2D image set. It's important to use all of the viewing planes. So if you digitize on a coronal plane, you would want to check that digitization on a sagittal plane, and then also check it on the axial plane. So important that you use all of those planes. And in a subsequent session, we're actually going to go through exactly how to do this digitization and exactly how to do the dose optimization. So we're going to save that conversation for that session.
Awesome. Dr. Brown, Kavuma is asking that Electa and HD or some other HDR vendors are promoting a unit where they can do both 3D imaging and treatment at the same position. Do you have any comment about that? Any insights?
Yeah, I think it's I think it's great. Like we said before, if you could insert, image, and treat without having to move the patient, that is the best option. Very, very much the best option. I don't know. I mean, I have never worked in a clinic there. I doubt I ever will. I think that is sort of something that's going to come at a relatively large cost. And I don't know how many centers, at least in North America, are going to be able to accommodate that. But it is a great idea. I love it. If you have the money to be able to do that, I would definitely recommend it. And for all of this, this is a really important point. I know we're sort of coming up to our timeline here. For all of these things, efficiency matters, right? So we're going to image our patient, and then we're going to do this digitization, contouring, and treatment planning, right? The longer we take to do digitization, optimization, and treatment planning, what happens? The more opportunity our patient has to move. The more opportunity our patient has to move. And if our patient moves, then we're going to mistreat them. So we want to do this correctly, and we want to do it efficiently. And the only way to do it correctly and efficiently is to find a strategy that works for you, and then practice that strategy, practice that strategy, practice that strategy until you can do it super quickly and super accurately. That's the goal here. Because the longer you have between imaging and treatment, the more likely it is that your patient is going to have moved and you will mistreat. All that effort that you spent doing this 3 hours of digitization and 2 hours of dose optimization, then you do this, you have this wonderful plan, and it's not even close to what your patient gets because they've pretty much crawled in across the room and away from the Tandem and Ovoid, right? So very, very important that this happens, that you get good at this before you do it in a patient. That would be a really important message for me. find a recipe that works for you, and then just practice it and practice it and practice it. Here, just showing lots of different sort of applicator models that we could use. Here is manual reconstruction. I would really advocate for this. So you're just using all of the planes available, all of the two-dimensional images that you have, and sort of reconstructing where the applicators are based on that. Okay, so we've digitized our applicators. So we have Tandem and 2 Ovoids. Now we need to know what our goals are. So what are our planning aims and what are our prescriptions? This right here is the document that we're going to use, ICRU report 89. So this describes recommendations for both 2D and 3D dose reporting. If you don't have a copy of this or haven't read it yet, I would highly recommend it. There's a lot of useful stuff in here. So for 2D imaging, we've talked about this already. We're going to use point A. We don't really have much of an option to do any dose optimization around this. And again, point A, 2 centimeters up the tandem, 2 centimeters laterally. And we're always going to be up the tandem. Okay. 3-dimensional imaging, treat planning aims and prescription, is now sort of dependent on imaging, right? So we're going to be able to see our organs at risk so we can optimize around them. We're going to be able to draw on those 3-dimensional images what our high-risk CTV or looks like, and then we're going to prescribe to that high-risk CTV. We do know from the literature that when we're able to do 3D imaging and we're able to define a high-risk clinical target volume, that typically we treat to a smaller volume than we do when we treat with point A. And this makes sense, right? Point A, we can't really see the anatomy, so we're forced to go big, right? Because we don't want to miss anything. But when we can start to see things and when we can start to define these clinical target volumes, we know that for 90% of our patients, it's actually point A would have been too much. But if all we have is 2-dimensional imaging, we're still going to treat to point A because that's going to be our best option. But typically, we're going to be treating to less than point A, and not for every one of our patients, right? But typically, we're going to be treating to a smaller dose than point A. We also have these EQD2 defined doses, also coming out of this Embrace trial out of Denmark. Sorry, everyone.
No worries. By now, I feel like everybody fully understands the whole virtual world and how there's so many unexpected circumstances. All right, well, until Dr. Brown comes back, Raham, I see your question. I'll definitely make sure Dr. Brown has a chance to answer it. Thank you so much. And yeah, please come get the questions coming. So far, we've had some great questions, and we all know that's the best way to fully understand as well. Dr. Brown, we also have a question before we dive back into the constraints. What do you think about the CT plan orientation, axial or paraxial, or you don't find a value and there's no difference in between the two type of images?
Between using the different planes?
Yes.
Yeah, I think you need to use
Axial, paraxial.
all of the planes. I think you need to use them all. They're all equally valuable and they're all equally important, and you really need to use them all. If you digitize on one plane, then you're very likely to be missing what's going on, right? It's the same way for 2-dimensional. If all we have are 2-dimensional images, we're still going to we need 2 planes, right? We have one from the side and one from the top. Otherwise, we wouldn't be able to localize that applicator. It's the same idea. You really want to make use of all of your imaging planes when you're doing your digitization. We sort of left off here talking about this total equivalent 2-grade doses. This is potentially a little bit confusing and probably too much for this presentation. We are going to talk about this in upcoming radiobiology session. So this is going to be covered, but this is sort of telling us over the course of our 5 fractions or 6 fractions or whatever it is, what our total dose to the target volume should be. Minimum reporting for 2-dimensional imaging should be, like we talked about, a bladder reference point and a rectovaginal dose point, sometimes or previously called the rectal reference point. And you can see they're listed here. So here's our Foley catheter inside the bladder. We're going to take the point that is closest to our ovoids. And then here we're going to our rectal point, which is 5 millimeters, sorry, from the posterior vaginal wall in the plane of the ovoids. Okay, so that's how we're going to track our doses, organs at risk for 2-dimensional imaging. When we do have 3-dimensional imaging, contouring, of course, required. And then we're going to look at our maximum D2cc and D.1 cc for bladder and for rectum. And then we're going to track those across all of our fractions, add those to our external beam dose, and then we'll get our total dose to those volumes. And that's what's going to allow us to determine whether or not those organs at risk, bladder and rectum and sigmoid, are getting too much dose or not. And we're going to change our plan based on that.
Thank you. There's also a question on any advice for the constraints to vaginal wall. Is there any dose constraints or what do you advise on vaginal wall dose constraint?
That's a great question. I'm not aware of any dose constraints. What we would want to do is keep our 200% isodose line inside the ovoids. So we wouldn't want 200% of the prescription dose getting into the vaginal wall because that could cause necrosis and problems in the vaginal wall. But outside of that, no strict dose constraints on the vaginal wall.
Wonderful. And there's also another question. If you have the same source arrangements for different patients' anatomy using your HDR unit, for instance, small tandem, length, and long.
Yeah. So we would want to have a standard loading pattern for each combination of tandem and ovoids that we were going to use. So we wouldn't want to use the same loading pattern for a smaller tandem that we would use for a larger tandem. So we would need to have sort of a bank or a library of standard plans.
Great, thank you so much.
You're very welcome. Again, from that ICRU report, we have planning aims that describe tolerances for bladder, rectum, and rectovaginal wall, sigmoid, and bowel. So all of that really good information is in there. Again, we'll describe what EQD2 means in subsequent lectures. Okay, went through that a little bit quickly, but here's our next poll question. What doses should be recorded for a 3D-based treatment plan using Tandem and Ovoid applicators? So again, let's go to the chat. Just put your answers in the chat here. Option A, point A, bladder reference point, rectovaginal reference point. Remember, we're talking about three-dimensional imaging here. TV D90, point A, bladder reference point, rectovaginal reference point, bladder and rectum D2cc and D.1cc, or HRCTV D90, bladder, rectum, or HRCTV D90, sigmoid and bowel. What do you guys think?
Yeah, since our poll functionality isn't working here, if you guys could type in your answers in the chat. We have A so far, B, getting a couple, some C's, more B's. Everybody has been listening.
I know, that's great. All right, everybody, that's great. And the answer goes to the majority here, B. So that's correct. We're going to record all of these across all of our fractions, and then that's going to give us our, whether or not we've managed to get enough dose to the tumor and managed to spare the organs at risk. Optimization, we can go about this in a number of different ways. Some manufacturers will allow you actually to grab the isodose lines and pull them manually. Other strategy would be to go into each of these dwell positions and change the amount of time in each of those positions. Just like with cylinders, we're going to want to have an independent second check of the dose calculation for each one of these plans. And we can do that in a number of different ways. We can create a spreadsheet. At a clinic that I used to work at, we actually created our own spreadsheet, which you see here. But there are also lots of different software tools that will perform the second check for you. Definitely mandatory, just as it was in the case of cylinders. And we want to do this for every treatment and every patient for treatment. Same again as when we did the cylinder, we're definitely going to want to do a timeout immediately before each treatment. And at a minimum, we're going to check essentially the same things that we checked for the cylinder. Correct patient, correct applicator, correct treatment plan, source strength, transfer guide tubes are connected, and that the room is clear and ready for treatment.